Assalamu alaikum. Welcome to today's cataract surgery insight into a posterior polar cataract with mechanical cortical cleavage dissection. I'm Dr. Rahman Muhammad Alam going to perform this surgery. I've made right and left sideboard with 1.2 millimeters NVR plate followed by main port creation with 2.4 millimeter steel keratom. I've stained the anti-capsule with Tryphon blue. Now I'm washing the Tryphon blue with BSS, followed by which I am placing OVD inside the eye. Now I'm placing a 5.5 mm rhexis marker over the cornea, which will help me in creating a perfect 5.5 mm curvilinear capsular rhexis. This is a polar cataract. You can see in the posterior aspect the polar cataract. In seeing this polar cataract, I have decided to do the surgery by lowering the bottle height to 75. In posterior polar cataract, you should remember that you cannot have a high raised bottle height because this can lead to spontaneous posterior capsule rupture due to pressure created from the high bottle height. So I'll be performing a low flow phacosurgery. Now I'm performing Alon's mechanical cortical cleavage dissection with the help of a spatula. Now I'll be performing hydrodelineation. And you can see the beautiful golden ring. Now I'm performing further hydrodelineation and you can see there is a second golden ring appearing in the cataract. Now with the help of a long ball chopper, I'll be performing mechanical cortical cleavage dissection around the equator. Also, this dissection is reaching the posterior capsule. Now I'll perform pre-phaco. Pre-phaco setting is bottle height 75, torsional energy of 30, aspiration flow rate of 26, and vacuum of 80. Now I performed mechanical quadrant division of the nucleus, mechanical quadrant chop, where I have not used any energy. Now I'll be performing emulsification of the chopped pieces. You can see my quad setting on the left hand side. In quad setting, I'm using a torsional amplitude of 80 and on time of 200 millisecond, off time of 50. This is a burst setting and bottle height of 75, aspiration at linear at 28 and vacuum at 280. Now I have switched to epinucleus mode. In epinucleus mode, I'm also doing it in burst mode. Then centripetally peel the epinucleus shell from the equator and with the help of a ball chopper rotate the epinucleus shell and aspirate and emulsify the epinucleus shell. Keep the ball chopper in the safe position and thereby you will not have any posterior capsular rupture. If you're confident enough, you can also remove a bit of cortex with the phaco eye handpiece, but it's highly recommended but in case if you are a highly skilled surgeon. But if you're a learning surgeon, you should avoid this. Now refill the anterior chamber with OVD. Whenever taking out instrument in posterior polar cataract, you should perform viscofluid exchange. I've decided to do bimanual cortical removal of the cortex with a bimanual eye handpiece. Viscofluid exchange is recommended while changing instruments in polar cataract because fluctuation in the AC dynamics can lead to rupture of the posterior capsule. All the cortex has been removed beautifully. A bit of polishing was done with the bimanual eye handpiece. Now, before coming out, perform viscofluid exchange and come out. Form the anterior chamber with OVD. Enlarge the main port to 2.8 mm prior to IOL implantation. Now load the IOL in the cartridge. Now refill the anterior chamber again with OVD. Now implant the IOL in the PC bag. I like to dial the IOL with the help of a spatula. I have successfully dialed the IOL in the PC bag. Now I'll be removing the OVD from in front and behind the IOL. All the OVD has been removed. Now perform stromal hydration of the side port and main port. Thank you, my dear friends. Hope this cataract surgery insight into a polar cataract was helpful in developing your surgical skills.